Good afternoon. I'm Alice Sheridan, and the editorial director for nephSAP, and I'm here with John Francis, our associate editor. And today we're speaking with Dr. Christopher Chan and Dr. Klement Yeung, and we want to hear their thoughts about home hemodialysis. By way of introduction, Dr. Chan did his medicine residency and renal fellowship at the University of Toronto and then joined the faculty in nephrology at Toronto General Hospital and the University Health Network. He is currently director of the Division of Nephrology and a professor of medicine. He was recently appointed as the provincial medical lead of integrated care at Ontario Health, with a specific focus on chronic disease management. Chris is an associate editor for CJASN and the president of the International Society for Hemodialysis. Dr. Klement Yeung, he completed his medical school and residency at McMaster University in Hamilton and is currently an adult nephrology fellow at the University of Toronto. Klement will be completing advanced training in home dialysis at the University Health Network and St. Michael's Hospital next year. Thank you, Chris and Klement, for joining us today. I look forward to hearing your thoughts about this important topic. My first question, it's all of us, or many of us in clinical medicine, nephrology, are trying to expand the cohort of home hemodialysis patients. And at least here in the United States, we've come up against many, many stumbling blocks and obstacles. The first one that I would love to hear your thoughts on is in terms of coverage for patients. What is the difficulty when we know we're accustomed to dialysis being covered? And it's a bit difficult, but perhaps if you could address the United States and Canada, it would give us an ideal framework.
Yeah, I think that's an excellent question. I think policy exerts a profound influence on choice of dialysis modality. And speaking from somebody north of the border, it's certainly different than in America, where here the treatments are covered. I do think that when incentives align, home dialysis can thrive. And I think it was in 2019 there was the Advancing American Kidney Health initiative, and I think that sparked some more interest in home therapies by linking reimbursement to home dialysis targets. But I think that there are still significant policy gaps. There's not enough dedicated funding for home dialysis training, and not just the training of the providers, but also the infrastructure support and ongoing support for those at home. And that causes issues down the line, because the goal is really to develop a sustainable model for those at home, and making sure that that is a priority, I think, is critical to shifting the paradigm.
So thanks again, Alice, for having us for this podcast. Both Klement and I were really delighted to have this opportunity to actually have an informal conversation. In regards to coverage for patients, one of the intent of this guest editorial is really to establish in our society, in our community in nephrology, to think about home hemodialysis as an established dialysis modality. That's why we called it a call to action. I think it's important to realize that for someone like myself who's been working in home dialysis for decades, there has been lots of thoughts about barriers and challenges and so on. I would like to flip that notion on its head a little bit, to start actually thinking of ourselves as an advocate, both for our patients as well as for ourselves. I think the number one barriers towards home dialysis adoption across the globe is education. To that aim, we have started looking at advocacy within the ASN through the ASN EPC efforts for home dialysis mentorship across the board in the international community, looking at really a manifesto to understand that home dialysis is really an important modality, and the education for ourselves and our patients is really a right. They need to know about this. In order for anyone to actually be prescribing home dialysis, particularly home hemodialysis, they need to be aware. And most of the time, our patients adopt and pick this modality because of freedom, their idea of autonomy, and also to actually have their own control. We are looking at a new wave of prescribing dialysis, which is really their goal-directed dialysis. What do they want out of life, rather than just simply looking at the mathematics of urea kinetics? And I think it's really important for us to think about both the clinical entity, the outcomes, the technology, also aligning our policies to really fulfill what we truly want to do, which is to provide life, not to actually make dialysis the only thing that our patients are really so obsessed about because they can't do anything else. And to that aim, I think it's really an important call. And we hope that this particular issue of nephSAP will also provide some global interest. And we particularly have the important pieces from both American perspective as well as international perspective to really leverage the international perspective, ultimately leading to change.
Thank you. One of the limits I've seen as a clinician, I've had patients get very close to completing training.
Mm-hmm.
One patient in particular, both he and his wife tried valiantly to undergo the training, and they just never completed it to the point that we were confident about letting them fly. And my patient was a fair. They were people of means. They were fairly well off, and they were able to hire somebody without any medical training, any medical background. And he was able to pay that person, and we trained that person. We've similarly had relatives of patients, a niece in one case. We were able to train the niece to come to the patient's house. They lived in a two-story, and
Yep.
it worked. Is that where the limitation is in funding that you were thinking of? Are there any thoughts of providing coverage, financial coverage, for an untrained person to become the care partner?
So I think the exactly as Dr. Chan said, our priority is to allow patients, so of course to provide excellent medical care, but also to allow the patients to have a good quality of life and have home dialysis fit into their life and not have their life revolve around dialysis. And I think the scenario in which you described is not an uncommon one where there's, certain patient factors for maybe that maybe make it difficult to be at home independently and perform their treatments independently. And for example, in Ontario, in our province here, there is coverage for home assisted dialysis. And I think that this is going to allow a much broader patient selection for those who can be at home. And I think that this sort of ties into the idea of needing a good educational program that is sustainable and where all the members have good communication across levels, from patient to the person administering the dialysis at home to the nurse who's on call for backup to the physician. And I think it's really when that process is set up well that something like an assisted program can flourish.
So, Alice, I think you brought up two really important themes. One is about home dialysis training, and the other one is about the growth of home-assisted dialysis. So let me tackle the training question first. I think there has been significant momentum to really look at home dialysis training, both as a service but also as a science. We and others have started looking at home dialysis training really to understand how to provide both the actual clinical training, but more importantly, to actually test for competency. Many times, patients are being trained, but have we actually really done the due diligence to actually check for competency? And often I remember thinking myself, well, how do we actually do that? So we and others started to look at different ways of medical education theories, and can we actually extrapolate that in the patient's realm? And I think to that aim, there has been a lot of effort to both understand the scope of education, what is required as a curriculum, how do we test, and also how do we actually check for competency. Time doesn't permit us to actually really get into details about this, but just to illustrate an example, we are now starting to use OSCE, well known to all of us in medical education and program directorship, to test our trainees' level of competency. And now we extrapolated that notion to our patients' training, so that we have both a formative evaluation as well as a summative evaluation at the end of training, knowing very well that at the time when we discharge our patients home, they're able and fully competent to actually conduct this complex skill. So I think there'll be more work looking at how to individualize training, and also how do we allow ourselves to understand the science of medical education, especially in patients who are chronically ill. I think the second theme, which is home-assisted dialysis, I imagine that home-assisted dialysis is going to be an area of growth. There is already home-assisted dialysis globally. I will speak to, for example, an existing infrastructure such as home-assisted peritoneal dialysis in France. There is already home-assisted dialysis in other parts of Canada. And we also have, within this issue of nephSAP, a discussion of home-assisted dialysis within America, which is emerging. And so I think there will be an important growth, especially as we're trying to actually expand the pool of patients undergoing home dialysis. No longer are we going to be only picking people who are, we know, quote unquote, fit to do home dialysis, but we're changing the philosophy of care to think about home first. Rather than always starting in-center hemodialysis, and then you have to demonstrate to us that you can and have the ability to do home dialysis, let's try it differently. Let's think about starting you in home dialysis. Only if you cannot do home dialysis, then can we talk about in-center hemodialysis. So I think both areas and themes are really critical as we extend home dialysis in the continuum of kidney replacement therapy. I think individualization of training is going to be both a science and an art. And I think home-assisted dialysis is going to be an area of growth. Our important distinction is going to be, how do we define and include everyone? And what would be the inclusion criteria, and who should select home-assisted versus home hemo training? And I think there will be more work that's going to be done across both in North America as well as globally.
Well, you presented an almost revolutionary idea that a home therapy would be the default, and it was only after they failed home therapy or rejected it in some way that they would be considered for in-center.
Right.
That would absolutely be a game-changing, a change
And
in how we do things. How long is the training for patients in Toronto, may I ask?
I might let Dr. Chan tackle.
so gradually, generally speaking, there is a spectrum.
Mhm.
It's about 8 weeks on average,
Mm-hmm.
which
Do
is
you? Yeah.
which is actually heterogeneous across the world. There is all kinds of different lengths of training, and also depends on how you train patients as well. Some programs train every day. Some programs train 3 times a week. Some people actually have remote training, training at home, even, and also some start with self-care and then switch over to home training. So it really depends on how you count. But generally speaking, across 8 weeks, and there's a lot of heterogeneity internationally.
And do you allow solo
Yes,
train? You do
yes,
in all of your patients.
yes. So
Ah,
again, this is an interesting distinction between, for example, Canadian practice versus American practice.
yeah.
And generally speaking, and I remember having this debate and also conversation with various different nephrologists in America. And it's quite arbitrary, isn't it, to say that you have to have a partner at home so that you can do home training, both PD and hemo. I think within our Zoom screen today, all of us have partners, spouses, and so on. There's no guarantee that there's going to be always someone at home when this person is going through a therapy. There is often a support person, and I think there is good literature to suggest that someone who have better home support flourish better in home therapies and also with chronic medical conditions. I think it would be a disservice to actually not include the possibility of home therapy just because the person is solo.
Sure, sure. Hey, do you ever get pushback from your patients or families regarding the burden of care that they are taking on?
Clement, do you want to start?
Yes,
And then I can supplement.
yeah, definitely. And so I think the conversation between patients and physicians is not just a one-time discussion. It's really a longitudinal relationship where you can share these ideas and get them provide information over a long period of time. And I think that helps ease them into it. But certainly there is a some resistance that comes up in regards to, for example, not wanting to medicalize the home
Mm,
or feeling like they're I don't want to use the word unsafe, but perhaps not prepared to manage all the complications that could come up during a sensitive treatment like dialysis. Um, so there are certain barriers for that, but I think a lot of it has to do with again the education and also the support system that's at each individual site.
So I think caregiver burden is an important component of how to maintain and also create a sustainable home dialysis environment. For the home dialysis team in Toronto, there is an ongoing relationship with the patient and the family, and also we offer respite. It's important for, let's say, a family member to take a vacation, and we allow someone to be backed up in the home dialysis unit in Toronto. And I think it's also important to provide both support, coaching, and create an environment that is safe for both the family and also the patient to actually undertake this therapy. After all, this is a chronic therapy. there's going to be ups and downs. There are going to be challenges with, let's say, accesses. There's going to be hospitalization. There are also going to be different type of interventions that's going to happen. And with those, you need to back up someone, and you also need to provide support. In fact, I think it's really critical to actually have a logistic mechanism to follow all of our patients in such a way that after these particular hospitalizations or medical interventions, that we provide that support. Previously, we have looked at our data and suggest that for every 100 patients, you expect someone to actually fall back every day. So you need to have a chair that is open, and from a system perspective, you need to model that to provide that allowance. I also think that it's important from a follow-up perspective that this is going to be helpful to think about how the team actually is able to work with our patients, so that there is a ratio of number of nursing staff for our patients, and also it is not simply looking at the physical act of nursing, but in fact, nurses actually are acting more like a coach for our patients and also with their families, because the adherence to therapy sometimes goes up and down, and we need to help them to actually get them back to their designed therapy and prescribed therapy.
One of the major stumbling blocks that I've come across is the reluctance to cannulate a fistula. And in fact, I had one patient, he was a fantastic, not only candidate, but went on, learned the procedure, was doing it well. He learned on a tunneled access, a tunneled catheter, because he crashed into dialysis. And then when his fistula was finally mature and ready to go, he pulled out completely. He said, I just cannot do this.
Well,
How do you address that? Is that a common problem in your experience? And what do you do about it?
so this is not a unique situation, Alice. I think I often get asked, what is the best access for home dialysis? My usual answer is the one that works. And yes, you can absolutely start with a catheter to do home hemodialysis. And yes, for someone who are able to actually use a permanent access, the outcomes are better with AV fistula and AV graft compared to central venous catheter. While this is true, there is a lot of different type of strategies that people have employed. One is education. Number two, topical anesthetic, and also use of different support. Three is also an integrated approach. And I have to tell you, throughout the years, we have done a variety of different multidisciplinary approach in order for someone to overcome needle phobia. Number one, this is not usual. This is not a usual scenario where cannulation ought to be natural. So expect that this is going to be tough on people. As I usually say, if your patients are already experts at self-cannulation, then they are doing something else that you're not aware of. Secondly, we have used both our colleagues in psychiatry as well as occupational therapy to actually create systems to desensitize or even decondition this phobia. So much so that we have employed cognitive behavior therapy as well as even hypnotherapy to actually do this. And so I think the whole act of allowing that flexibility to think about how to help someone to undergo self-cannulation is going to require more than just nephrology. And then the final thing that I would say, if there is so much needle phobia that the person cannot do it, we have then elicit help with family to cannulate, and also thinking about just is it possible to continue with a CVC? So all of the above has happened, but generally speaking, it takes somewhere between 12 months up to 15 months to transfer someone from a CVC to a fully competent cannulator. So it takes time.
That's a fantastic answer, actually, and extremely helpful. I wish I had that patient back, and perhaps I would have handled it slightly differently and kept his catheter in for a bit longer. And probably the final question. All of us involved in fellowship training programs are trying to tweak the program to allow adequate education in home hemo, as is required, obviously, by ACGME, and as is most appropriate to serve the needs of our communities. We're limited by the limited cohorts of patients. Any suggestions? How did you get started in Toronto that allowed your fellows to learn? How'd you do it?
We should start with the fellow's perspective, and then I'll supplement.
Absolutely.
Yeah, I think that's a really interesting question. Based on the literature that I've read thus far, there are a lot of trainees across different sites that feel like they haven't had as much exposure as they would like in this field. And I think that in itself creates a cycle. If you don't feel comfortable as a trainee and you didn't get that exposure as a trainee, then you're not going to be as comfortable prescribing it when you're the attending nephrologist or staff nephrologist. You won't have necessarily the experience to set up a program or help a program to grow or flourish. And so I think it does really start with the education. I think that you also don't necessarily want to just have exposure to one program and the way that one person or one group of people does it, but actually getting exposure to different health systems and different ways that people employ and push and advocate for home dialysis and how they make it work in their local area can give a lot of insight into how you might want to do it when you are in that position. And outside of that, I would say that again, it starts with the education level. I think that we're really at a point where we can make this home dialysis from a clinical niche to an established modality, and I think it's something that's within reach. The goal is to make it really embed it into the kidney care landscape, and by providing good education to the fellows, the nurses, the patients, the people actually performing the dialysis. I think only then, from a collective standpoint, we'll be able to push it forward.
Klement, could I ask, as a clinical fellow, did you have the opportunity to round on outpatient home hemo patients?
Yes. So as part of our curriculum here in Toronto, we do have several home dialysis blocks involving both peritoneal dialysis and home hemodialysis patients. And so I think that exposure is something else that one gave me a bit more exposure and comfort or competence in assessing and prescribing for these patients, but also piqued my interest more because
Yeah.
you can't be interested in something if you don't see it.
Absolutely. I have to say, we just finished our interviewing season, and the match list just went in. And that was the most common question I got from candidates is how much home hemo are you able to provide? Chris, do you want to add at all to
Yeah, I
Clement's
think
excellent response?
it's an at the more macro stage. I think home dialysis as a whole is an important core curriculum and competency for nephrologists. And in Canada, it will be unheard of for someone not to have exposure to home dialysis to graduate as a nephrologist. And I think organizationally, we need to create the learning environment so that there is exposure to outpatient home, both hemo and peritoneal dialysis, not when the only exposure is someone has been admitted because of some sort of complications, because that actually skew the actual awareness and exposure to what home dialysis is like. And to that aim, that actually is the same for both home hemo and home PD and medical and nursing and other allied health as well. And so we are fortunate that we have a center of excellence model where in UHN, while prevalent home hemo patient population is around 90 patients, up to 100, and home PD is around 150 patients. And collectively, about 40% of dialysis patients at UHN are dialyzing at home. So there's a lot of patients for trainees to see and also to understand the different presentation, and as a result to be an expert to troubleshoot. Collectively, looking at a more global environment, I foresee that I think there is going to be a need for center of excellence hubs for students and trainees to actually visit and to understand the development and the practice of home dialysis, because I think an organizational structure is important, and also to allow them to feel the appropriate amount of exposure. In my other various roles, I also have the privilege of working with the USRDS committee as a committee member, especially to advise on home dialysis. And we see that the current US stats shows that the most popular or the average number of patients in the US home program is somewhere around a dozen. So not, and that's both home hemo and home PD combined. And so it doesn't allow for a lot of exposure. Right. So it will be important for attachment to happen, for experience to be gleaned, mentorship programs to provide further education, to actually really round out the experience. And I think this is going to be an important area to continue to develop, and also to create the education environment that everybody wants.
I completely agree. I see Martina McGrath has joined us. Thank you. And John Francis, do you have any additional questions for either Chris or Klement?
No, I just want to learn from you about your attrition rate. Like, let's say, you said you're 90, 100. Are you losing equally to what you're recruiting every year? And how do you see your attrition rate? And how do you fight it?
Yeah, so maybe I'll take that as this might be more operational, and Klement may not have to delve into that detail of the program yet. So in order for one to actually establish and grow a program, obviously, and I think the accounting is fairly straightforward, that the input has to be higher than the exit rate. The attrition rate in the current USRDS, in fact, we actually made a figure, and I have spoken to Kristen about it. This is an important figure in the home dialysis chapter at the end of the chapter, where the US attrition rate is relatively high compared to the rest of the world. The Canadian attrition rate is relatively low, and the usual exit is in home hemodialysis tends to be transplantation, and in terms of 2, 5, and 10 years attrition rate, again continues to be low. There might be multiple different reasons for that. The idea of a regional hub centers tends to be the norm in Canadian nephrology relative to American nephrology. There is no LDO in Canada. There tends to be relatively big programs rather than small programs. So I think the critical mass is significantly higher in Canadian nephrology versus American nephrology, just because of the structure of how care is being delivered. Finally, I think there might be difference in systems, globally speaking, in terms of follow-up, the team dynamics. So, for example, just in terms of the structure perspective, the hospital where I'm sitting at right now also housed the in-center dialysis program, also housed the home dialysis program, both home hemo and home PD, our vascular access coordination, as well as our CKD program, and have nurse navigation within one roof. This is going to be very different if we ask the general US nephrologist of how many programs and how many units do you have to visit per week to actually cover both in-center dialysis, home dialysis, and elsewhere. So I think the logistics and the efficiency and also the ability to coordinate care is much more centralized. And so I think from a system perspective, we're creating an ecosystem that actually benefits home dialysis, whereas the way that the current structure is being done, sometimes for a different purpose, actually creates different inefficiencies that makes care sometimes more laborious.
I fully agree because, in our center, PD is very well structured. Home hemodialysis, you have like 1 or 2 patients per attending. It makes it very hard for a fellow, like who's going to shadow? We don't have a centralized, Dr. Chan, who's seeing like 50 home hemodialysis and can assign a fellow or 2 or 3 to can rotate, so they can rotate and learn it. So I think this model has to be much more organized for us to be able to train people on the home. We did that in PD. PD is very well structured, I see, but not the home.
Absolutely.
We have much to learn from our northern neighbors, is what I firmly believe.
Exactly.
Martina, unless or John, if we have no further questions, that was absolutely a fantastic session. And I really thank you for your time and your expertise. I look forward to this issue coming out.
Again, on behalf of both of us, I would like to thank the committee for the opportunity for this guest editorial and also for highlighting the importance of this issue. And I think I've also been involved in different nephSAP series before. Perhaps as an author, I should also thank Alice for all the work that you have done and been really just a champion for the nephSAP series. So on behalf of ASN, thank you as well.
You're very welcome. It's been a pleasure.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.